disciplinary management. Can we really afford that? Can our patients really afford it? My personal feelings are that it is high time that we revert back to the internist who take care of heart, lungs, kidneys, liver, GI. Of course, they be given some kind of a limitation, lines drawn clearly that this is when you are required to refer your case to a cardiologist, to a hepatologist, or to a gastroenterologist, to pulmonologist, and all that. And I think it is high time that we think about it once again. Our country probably, with the current economic situation that we have, we need more internists. I'm sure you must have seen this slide earlier on as well, that when we used to talk about managing diabetes, it was earlier assumed to be managing the hyperglycemia. It was glucose-centric. UKPDS, you've just heard about UKPDS. That was the first time we realized managing hypertension and dyslipidemias are more rewarding so far as cardiovascular disease is concerned as compared to managing hyperglycemia. So we included management of hypertension and lipids and all that. And I think in one of the previous sessions, which unfortunately I could not attend, there was probably a talk on the triangle, the cardiovascular, kidney, and metabolic triangle. I mean, you will hear about so many other triangles, the triangle of diabetes, cardiovascular disease, and liver. But whether these are triangles or pentagon or so, whatever you may call it, but the hard fact is we are required to focus on the metabolic derangement associated and organ damage. These are all end organs, may it be heart, may it be kidneys, may it be liver, may it be now we believe so many other which are affected by metabolic derangement. So I think at the end of the day, we are required to take care of all these things rather than just focusing on individual organs. And I repeat once again what I said earlier on, only an internist can decide that. And let it be left to the internist to refer the case to a cardiologist and other specialists when required. Traditionally, fatty liver disease has been a disease for hepatologists to take care of. But as we understand, considering its very high prevalence, there is no specialty nowadays left where patients do not present with fatty liver. But still, at this point of time, the hard fact is the disease is still missed even in high-risk patients, as I've just presented a case to you. And what does this result in? Untimely, since the diagnosis is not made in time, so there is either no referral or the patient ends up having liver-related or metabolic-related complications. So I have another point to make, and that is, it is desirable to empower some of the additional specialties, not just our primary care physicians. It is desirable to empower our endocrinologists, our diabetologists, our cardiologist colleagues, not only to think about it, diagnose it, and treat it. Of course, they have to be told the limitations that if fibrosis is beyond this particular level, that is the time that they should be referring the cases to hepatologists. Now I'm talking about managing these patients in our own country. A few words about the nomenclature. MASLD was the term which we have been using since 1980. This is just excess of fat in the liver in the absence of significant alcohol consumption or in the absence of other specific causes for fat in the liver. So you can imagine that this is more of a diagnosis of exclusion. More recently, two names are in use. In the Southeast Asia, MASLD, which is metabolic dysfunction associated fatty liver disease, that is what is more popular. But in Europe and in North America, metabolic dysfunction associated steatotic liver disease or MASLD is more popular. And in our own country, our own societies have also preferred MASLD as the term to be used. Now, how do we define MASLD? What exactly is MASLD? MASLD is excess of fat in the liver in the presence of either obesity, pre-diabetes, diabetes, hypertension और dyslipidemia. किसी भी शख्स के जिगर में अगर फैट ज़्यादा है अल्ट्रासाउंड पे या किसी भी और मोडालिटी पे और वो ओबीज है या उसका फास्टिंग ग्लूकोज ज़्यादा है या इम्पेयर्ड या वो डायबिटिक है, हाइपरटेंसिव है, डिसलिपिडेमिक है, तो should be labeled as MASLD. So it's a more of an inclusive type of a definition rather than an exclusive type of definition as was previously used. Of course, MASLD can coexist with so many other diseases. One can simultaneously have alcoholic liver disease as well, can have drug-induced liver injury, and so many other conditions, because we realize that presence of fat in the liver could be due to a host of conditions. So MASLD can coexist with all those. Now, there are two main phenotypes of MASLD. Now, I apologize at this stage that during this presentation, some of the slides would still show you NAFLD or NASH, whereas the current recommendations are MASLD and MASH. I may also be using these terms for the same purpose because the audience may not be well versed with these new terms. So the two main phenotypes of fatty liver, one is MASL, which is just excess of fat in the liver and nothing else, so maybe very mild inflammation. And then is a more aggressive form of disease, where in addition to fat, we have inflammation of liver, we have evidence of hepatocyte damage, and we have evidence of fibrosis. Now, it is this form of fatty liver or MASLD which is expected to progress to liver cirrhosis and liver cirrhosis related complications as well as hepatocellular carcinoma. This is just to show you the prevalence of disease. It is there all over the world, and you can see that the global prevalence is something like 30%. So close to 1 out of every 3 individuals globally in the adult population is expected to have MASLD. You can see the distribution in different regions, Latin America having the highest, then Middle East and maybe South Asia. And unfortunately, so far as the prevalence of MASLD is concerned, it is on the rise. You can see right from 2006 on to 2020, the prevalence is still rising. Now let's see what happens to the fatty liver if somebody has diabetes. What is the impact of type 2 diabetes on MASLD MASH? Now whatever modality or diagnostic tool we use to diagnose MASLD, you can see that patients who are diabetic, in them the prevalence of fatty liver or MASLD is at least twice that of those who are non-diabetic. And even in individuals who are obese, if they have diabetes, in them the chances of MASLD are higher as compared to those who don't have fatty liver. And this is more prominent in individuals who are either overweight or who have first stage obesity. It is not just that diabetes increases the prevalence of fatty liver, it increases the likelihood of the severe phenotype of fatty liver, the MASH, what we previously used to call NASH. Whereas in general population, the overall prevalence of MASH is 5%. You can see the prevalence of MASH among the diabetics is more than 37%. So diabetes actually increases the severity of the disease as well. And unfortunately, presence of diabetes is also seen to be associated with more advanced fibrosis, no matter which method you use to measure fibrosis of the liver. Now let's see what is the impact of MASLD on type 2 diabetes or metabolic syndrome. We all realize that insulin resistance is the single most important pathophysiological mechanism both for diabetes as well as for MASLD. Now, if you look at this, diabetics without MASLD, they have HOMA-IR score of 3.1, but once they have fat in the liver, it is 4.3, and once they have more advanced fatty liver disease like NASH, it is 6.8. So presence of fat in the liver increases the insulin resistance further. It is not just the systemic insulin resistance which is increased in the presence of fatty liver. Insulin resistance, when estimated in different organs or regions like adipose tissue and liver, that is also increased when fat is there. And you would notice that as the disease progressively worsens from just fat to NASH, insulin resistance also increases. We believe that MASLD is a predictor of type 2 diabetes mellitus. It is associated with increased occurrence of type 2 diabetes independent of other common risk factors for diabetes. And this risk also is would increase with the severity of fatty liver disease. So like if it is just fat in the liver, it is 25%, and when there is inflammation, cell necrosis and fibrosis in the liver, this uh, uh, you know likelihood of diabetes increases to 55%, and similarly when fibrosis in liver is advanced, it increases to 89%. Now, there has been a combined meeting of EASL and EST in 2016. I had the pleasure of attending that meeting, and it was recommended in that meeting that all MASLD patients be followed up annually with A1C, fasting blood glucose, or even oral glucose tolerance if it is suggested. Unfortunately, this is still not being practiced. This is too complex to be discussed, and let me give you a simpler view of the hypothesis how would presence of fat in the liver cause type 2 diabetes. So we believe that whenever there is excess of liver fat, that excess of liver fat would stimulate the PKC, which would result in insulin resistance. And that insulin resistance results in hyperglycemia even in the fed state. The hepatic glucose output will not stop even after we have taken food because of insulin resistance. And that hyperglycemia would stimulate more release of insulin by the pancreas, so there is hyperinsulinemia, and that hyperinsulinemia would stimulate further de novo fat production within the liver. Once more and more fat is produced in the liver, that extra fat is exported to different organs of the body, including pancreas. Once in the pancreas, that extra fat earlier on would result in dysfunction of insulin, and thereafter it would actually cause damage to the beta cell. So remember, it is not the glucose, it's the fat which damages it. This is the whole twin cycle, but it is exactly what I have already talked about, and in the interest of time, I would move on. So, ladies and gentlemen, what I have said is that fatty liver disease or MASLD is presence of excess of fat in the liver, and type 2 diabetes mellitus is presence of excess of fat in the liver and in the pancreas. Now, there have been several studies like direct or counterpoint or retune studies which have categorically shown that drastically reducing the intake and resulting in significant weight reduction would result in loss of fat from liver as well as loss of fat from pancreas, and it can cause reversion of diabetes. So diabetes is not irreversible, it is very much reversible provided this extra fat can be removed. I think I maybe have one or two more slides. You don't have to do that, just two more slides. So, ladies and gentlemen, both MASLD and type 2 diabetes, they have bidirectional relationship. You can see that diabetes mellitus not just increases the prevalence of MASLD, it increases the risk for MASH, it increases the risk for cirrhosis, and it increases the risk for hepatocellular carcinoma. Similarly, MASLD would worsen insulin resistance, it would increase the risk of type 2 diabetes mellitus, difficulty to, and it of course makes management of type 2 diabetes more difficult. It increases the risk of atherogenic dyslipidemia, and it increases the risk of CVD as well as CKD. I think this is where I would require just a minute or so, and then I would stop. It all boils down to excess of caloric intake. Excess of caloric intake leads to metabolic stress, and that is what puts the entire metabolic machinery to stress, and there is a lot of metabolic waste, and this is what results in insulin resistance, and that metabolic waste would stimulate the innate immune system. When chronically stimulated, it results in chronic inflammation and fibrosis, and this is how we try and explain damage to all these different metabolic and organs. Now, these are some of the medications which can be more useful if a diabetic has MASLD. I will not go into detail. Our colleague is expected to talk about it. All I have to say is that a couple of decades back, when statins were first introduced, we all were enthusiastic. And statins have done so good to our patients suffering from cardiovascular disease. Similar to the discovery of statins, GLP-1 agonist as a group, I have a feeling, is a huge discovery. And this is the superhero because this is expected to neutralize, reverse a lot of metabolic derangement induced damage to the end organs. We do have semaglutide and lira and a couple of other in our country, but elsewhere in the world, tirzepatide and the triple receptor agonist and much more would be available. We expect GLP-1, GIP-1 receptor agonist with amylin and other. So this is the group which is expected to be to gain more and more attention, and but not to forget the importance of